Hypertension is COVID in the heart. As we know, the coronavirus enters the body through the spike proteins, inducing the internal body cells to produce viral mRNA. It affects the heart through various presentations. First, we have to remember the management of acute coronary syndrome patients in the COVID era. This is the APACI statement saying that we should consider all patients admitted with acute coronary syndrome as having COVID. In Milan, 40% of patients with STEMI-like presentation actually did not have a culprit lesion. For a non-STEMI, 63% on angiography did not have a culprit lesion. Now, which patients we should have immediate cath? ST elevation MI, non-ST elevation acute coronary syndrome with high-risk features. Urgent cath within a few days for non-ST elevation acute coronary syndrome with moderate risk, unstable angina, left main PCI, and class 4 angina. Lower priority, doing the cath within 3 months, PCI of the non-infarct related artery and class 3 angina patients. Elective, meaning you should postpone the cath more than 3 months for CTO patients. Now, myocarditis. Until now, it is still unclear. Initially suspected to occur quite often, but later data showed that it occurs in about 20% of severe COVID patients admitted to the intensive care unit. A recent CMR study showed a high incidence of late gadolinium enhancement abnormalities. However, subsequent histopathological studies failed to detect viral invasion of the myocardium. Current paradigm is that myocarditis is a consequence of cytokine storm rather than true viral invasion. Hypertension. As the coronavirus enters the cells via the ACE receptors, initial fears were that it could impair the effect of angiotensin-converting enzyme inhibiting drugs used for hypertension. However, trials did not prove this issue. Subsequently, other trials showed no need to either increase or decrease the dose of these antihypertensive agents. The current recommendation is to continue with the usual dosage with no adjustments similar to other drugs. Now, the effect of COVID on the blood vessels and anti-thrombotic therapy is a hot topic. As we know, COVID-19 induces an endothelial thromboinflammatory syndrome in severe cases. Anticoagulant therapy may improve outcomes in severe cases in the ICU, having coagulopathy such as DVT and/or mechanical ventilation. The role of anticoagulants for prevention and regarding which drugs and the duration is still under trials. D-dimer is a marker for both coagulopathy, only if more than 3-fold increased, but is also a marker for more bleeding. So it is also nonspecific and frequently, in mild cases, will drop spontaneously within 48 hours without therapy. Anticoagulants, we have to remember, do not decrease D-dimer on their own. ICU patients, as we mentioned, may develop DVT in about 19 to 30% of cases with possible subsequent pulmonary emboli. Heparin and low molecular weight heparins decrease pulmonary embolism and have anti-spike protein actions, that is, they are antiviral agents, as well as anti-interleukin 1, interleukin 6, and interleukin 8 activity, which are all involved in the cytokine storm. Trials are currently underway to establish their optimal dose and whether it should be prophylactic or therapeutic dose. Antiplatelets are also important because COVID infects the endothelial cells via ACE receptors in all vascular beds, leading to endothelial dysfunction and platelet aggregation. Although prescription of aspirin and newer antiplatelet agents seems logical and intuitive, yet no data exists regarding the role as of yet. Moreover, they may be of harm if combined with other anticoagulants. These drugs should be continued as usual when clinically indicated in selected patients such as coronary artery disease patients with acute coronary syndrome or post-MI. Sports activities in the young is a very important issue because COVID-19 affects many young people, many of whom exercise or play active sports. Now, myocardial injury may rarely occur in the asymptomatic or mildly symptomatic. 20% of hospitalized, severely symptomatic, develop myocardial injury by high-sensitivity troponin. In the non-hospitalized with mild symptoms, troponin testing should only be done after 48 hours of any sports activity, as it could be falsely elevated. If high, still you should repeat again after 48 hours. If it remains high, then you should refer the patient for CMR for signs of active myocardial inflammation. Otherwise, CMR is nonspecific and may be misleading. Regarding when they can return to sports, for those who had severe symptoms, you should wait 3 to 6 months before return to sports. Those who had moderate COVID, prolonged fever, you should wait 2 weeks before return to sports. For mild COVID or those who had close contact, 2 weeks before return to sports. Thank you for your attention.